There's a lot of debate going on in the breast cancer field about lupectomy and mastectomy and whether they're needed or not. Could you speak about what these techniques are and what your thoughts are on when they're required in regards to a specific type of cancer?
Okay, well, lumpectomy and mastectomy, it's good to take a really long-term historic focus at where we've come in breast cancer. So I'll take us back a little bit. The first medical treatise talking about how to manage breast cancer comes out of the ancient kingdom in Egypt, the old kingdom in Egypt, and it was translated in the late 1800s using the Rosetta Stone. And what it said was, in essence, when you have a cancer in the breast, as long as the glands underneath the arm or the lymph nodes are not swollen, you can cure some of those people if you take a hot poker and burn the tumor back to a distance of the width of a dung beetle's back beyond the tumor. The width of a dung beetle's back happens to be 10 millimeters, and guess what? Most people doing lumpectomy today are trying to take out the tumor with a rim of 10 millimeters of normal tissue in all directions. So one of the first things is that history tends to repeat itself. Now, by sort of 100 A.D., Galen, a Roman physician, had decided that melancholy was the cause of cancer and wrote a treatise, Carcinogenica Melancholia. He proposed that you should treat the cancer with a variety of herbal teas, one of which we would know today is St. John's wort, because if you could resolve the melancholy, you could take all the evil humors out and prevent people from dying of their cancer. That didn't work very well, but it was the mainstay of treatment until the mid-1800s. And in the mid-1800s, a Viennese surgeon by the name of Billroth, who's known for a lot of GI surgery stuff, proposed that we should go back to a lumpectomy with a 1 centimeter rim of normal tissue in all directions and take some lymph nodes underneath the arm, and that would cure women of breast cancer. Unfortunately, about 80% of women had cancer recur within the breast within 3 years. By the end of the 1800s, William Stewart Halsted, who was the first chief of surgery at Hopkins, had identified that mastectomy could cure women if the nodes were negative. Didn't cure all women, but it could cure a large percentage of women if the nodes were negative. If the nodes were positive, the disease was already beyond the breast, and the chance of curing the women was much lower. That obviously became the mainstay of treatment for many years, and then by the time we got to after World War II, people began to dabble in lesser surgeries, and we got back to, in the late 70s and 80s, lumpectomy with radiation as being a treatment. Lumpectomy, lymph nodes, and radiation as being a treatment. We now have progressed through the 1990s of being more specific as to which lymph nodes to take out, fewer and fewer lymph nodes to take out. So we're still left with lumpectomy and radiation versus mastectomy as treatments for breast cancer. The bottom line is, if you have an invasive cancer, you have a chance that seeds of your cancer have spread beyond the breast. They may not all germinate this year or next year. They may sit silently for years before they start growing, but any seed that's out there that ever grows can get you into trouble. And the best prediction of there being something out there that we don't know about or can't see on scans and blood tests is evidence of tumor cells within the lymph nodes. So with both lumpectomy and mastectomy, if you have an invasive cancer, you need some lymph nodes sampled. That can be done through sentinel node technology, which is more accurate and more specific, looking at the lymph nodes that drain where your tumor was within the breast. And mastectomy and lumpectomy and radiation are roughly equivalent in terms of survival. Obviously, you have the amputation deformity of mastectomy and the numbness and so forth that goes with that. With lumpectomy, you get to save a breast mound. It might be a little bit smaller. It might have a big incision there. It might be a little more tender because the radiation is going to make the breast swell a little bit and hold on to water. But your overall survival is the same. But with lumpectomy, you run at least a 1% per year risk of having a second or recurrence of that cancer or a second cancer within that same breast. So if a woman is in her 20s, mastectomy is by far and away a better option. By the time you get to be 50, 60, 1% per year, doesn't sound too bad. There are many other things worse than that more likely to happen to you, and you're willing to put up with that little bit of a drippy faucet to the treatment. Both work equally well for survival. In the in situ cancer, ductal carcinoma in situ, we can just eliminate the lymph node part out. Now, lumpectomy without radiation was the treatment, remember, in the 1800s. So we know in the majority of cases that doesn't work, and where it's been tried again, yeah, it doesn't work terribly well, and that's because there tend to be some cells spread in the breast tissue, either close to the lumpectomy or elsewhere in the breast, that can be killed by the radiation. So radiation reduces the risk of recurrence. If you have a limited life expectancy, 5 or 7 years, then it may not be worth it to do the radiation. But if you have a life expectancy of 20 or 30 years, the radiation is going to substantially decrease the chance of having the cancer come back. So most standard treatments today will be lumpectomy plus radiation or mastectomy. And that's unfortunately where we are. You would hope that we had progressed a lot. We'd have more therapeutic options than they had in the 1800s, but we've only made a minor bit of progress there.
Would you say it's absolutely necessary that we get all the cancer cells when we do these treatments with the radiation and the lupectomy? Is it absolutely critical that all the cancer cells are killed?
Well, between the surgery, the radiation, the chemo, the hormone therapy, and the body's own immune system, I think it's necessary that all the cancer cells be killed or made dormant where they don't grow. If they're held dormant for a long time, I don't think it necessarily means we have to kill them, but we just have to prevent them from ever getting a signal, a trigger to start growing again. So that's a pretty tall order in a cancer treatment usually, particularly for an adult patient who may have had their tumor evolve slowly over decades. And it has the ability to dodge lots of our therapies.
Could you speak a little bit about preoperative focused microwave therapy? Is this treatment specific for breast cancer, or can it be used on a variety of cancers? Could you speak about what this microwave therapy is for our audience?
Yes. Tumor cells in general of any kind are much more sensitive to microwave generated heat than other forms of thermal heat. Most of the time, to kill tumor cells with heat, you have to heat them up to about 60 degrees centigrade, and at that point you're beginning to actually cook tissue. And it's literally like cooking it on the stove. And microwave is very fascinating in that tumor cells of all kinds heat up much more quickly than surrounding normal cells do. Particularly invasive cancer cells heat up much more quickly. And the biology of that can be argued a good bit as to what the underlying cause, but I don't think we understand that fully. It's just a very interesting empiric observation that's been made. That's been used as early as the 60s to treat skin cutaneous recurrence after mastectomy, that sort of thing, in combination with radiation and chemo. And radiation and chemo often can be much more effective if given at a slightly higher temperature than body temperature. It can greatly magnify the effects of chemotherapy. So the focused microwave therapy is actually an attempt to use very low wattage microwave generators, 50 watts, as opposed to your average microwave at home that might be 1200 watts. Use 50 watt microwave generators and to focus the microwaves at the tumor and allow the tumor to heat up several degrees warmer than the surrounding tissue so that it begins to die from the microwave heat itself, and while you're giving other treatments like chemotherapy, which is also enhanced in activity to the heated cells. So you're allowing the tumor to develop its own biologic margin, in essence, because the tumor cells are going to heat up more rapidly than normal cells around it. So it's a way to sort of play off biologic differences between tumor cells and normal cells and use it to our advantage to kill tumors more quickly. The initial pilot studies, the phase 1 and phase 2 trials with that were very effective in conjunction with chemotherapy, and we are about to launch an international clinical trial, randomized clinical trial for adding microwave energy onto preoperative chemotherapy for patients with large tumors, bulky tumors.